Let me try to make sure we can get this, start the first slide. There we go.
So we'll wait till I think the moderator is supposed to join, so we'll give her a few seconds.
Just wait for your
Yeah.
cue to join. Start.
Imran, can you share the link with Dr. Kanitkar for general participants?
Oh, okay.
Yeah. Okay. We have Rishika joining now.
Yeah.
Hello, Rishika.
Hello, it's so nice to have you here.
Yes, Rishika, I'm Neeraj Kak. Even though there are two Neerajas, the other is Imran, and Imran is my colleague based out of Canada. I'm in Amman. Then Chris is there, and then Dr. Gate, and then of course Dr. Kanitkar. We do not have Dr. Guleria yet on the screen.
Okay.
I believe he was catching a flight or something else. So your panelists may be just Dr. Kanitkar and Dr. Gate at the moment. And then we'll see if we need to invite someone else, and we'll give them that access at that time. So in terms of process, will you introduce Dr. Murray before he speaks?
Absolutely.
So, and you have all the bios and everything else, right?
Yes, I have everything.
All right, so I'll just say God bless us all.
Right. Well, I think
we're in your good hands.
Yes, well, I think, at the very outset, I'd like to congratulate everyone for conducting this webinar, because I think this is a very important conversation, something which is extremely relevant to us here in India. And I say this, that it's relevant more here in India, because I think the loss that children are facing as a result of schools being shut is immense. There are recent surveys that have been conducted which show that only about 10% of children have actually had some kind of an education in the last 10 years. So sort of talking about that at a time when you're also talking about a very real health and safety risk is extremely important. So we're really looking forward to what our esteemed panelists have to say. One sincerely hopes that there is tangible conversation outcomes from this 1.5 hours. It is, of course, privilege to introduce what we're talking about. Schools reopening in India, how confident can we be? This is, of course, going to be drawing from insights on COVID-19 data that's available globally. And I want to just begin by introducing Dr. Chris Murray. He's the Director, Institute of Public Health Metrics and Evaluation. He's Professor and Chair of Health Metric Sciences, University of Washington. Dr. Swati Ghate of the Indian Academy of Pediatrics. Dr. Neeraj Kak, who you already heard from. And of course, we have Dr. Vandana Krishnan. She is Vandana Krishan. She is Secretary Education, Government of Maharashtra. So thank you all very much for being with us. I'm going to, of course, keep coming to all of you for comments, but Dr. Chris Murray, it's over to you.
Thank you very much. And it's a great pleasure to be able to speak about the risks of COVID to children, particularly in India. And I'm going to run through these topics, trying to take a sort of broad view of both not only the risks from COVID, but the risks from the pandemic in the sense of the mental health consequences in addition to the direct effects of the virus. I won't cover, but it is absolutely the other balancing side of the equation, the impact of on education, human capital that is immense from schools being closed. So just to tell you the perspective that we use at IHME when we are thinking about the pandemic is the very first step is to understand what has been happening in each location. And we do track states within India, and not India as one nation. It's obviously too large to track as one place. And the way we do that matters. And so I'll just take a moment to go through this slide. namely that we start with reported cases on the top left and reported deaths on the bottom left. Now, in both cases, we don't think, as everyone on this webinar will agree, that those reflect the reality in the sense of the number of infections in the community, because many infections go undetected, and many deaths, depending on the country, go undetected or incorrectly assigned to other causes. So what we do on the far right, in the middle panels, we take the seroprevalence studies that ICMR has done, and we do this country by country, state by state in large countries, and we back calculate what is the infection detection rate that matches that seroprevalence survey. And that's this little middle panel in the middle, it's labeled IDR. And that says that in Maharashtra, the infection detection rate has been around about 5%. So 1 in 20 infections being detected. Some states it's 2% in India, some states it's as high as 7 or 8%. Now, the driver of the infection detection rate are attributes of the health system, but primarily access to testing. And so we see that this is why we then try to have a sense of what we think will happen to the infection detection rate after the last measurement, and that's based on testing availability and other covariates. And then down here on the infection fatality rate, at the beginning, the IFR was very high when there was very few deaths, very few cases, very little knowledge, but it's settled into less than 0.5% in India. This panel takes into account what I'm going to show you in a moment, which is correcting the reported deaths for under-registration. And we can do that using civil registration data in India for about 11 or 12 states. Now you put that all together at the global level, and what we see is on the top here is global infections, which ran about 5 million a day from June of 2020 right through till January, February of 2021, started to decline, and then the Delta wave hit in India. And this huge surge in daily infections is not exclusively India, but very much mostly India. And we got up to about 16 million infections a day. And after the Delta wave went through India and other countries in South Asia, there was a sort of a reduction. And then the Delta wave hit Europe and Southeast Asia and the United States. And that's the second wave. And now we're in this decline. And we do expect, for those who are interested, that numbers are starting to go back up. So infections the last 2 weeks, not shown on this diagram, are actually starting to increase again. Well, this leaves you with an overall metric of how bad has the epidemic been, which is the percent of the population infected with COVID, any strain. And you can see many states in India are in the 70% or higher, some are in the high 60s. This is particularly important when we think about risks, because we do think that natural infection has considerable protection against future infection. And as we'll see towards the end of my presentation, it may be, and I emphasize the word may, that natural infection wanes more slowly than vaccine-derived immunity. And so that gives quite a degree of protection in India, as we're now seeing in countries in Europe, for example, where countries that did a better job, like Germany, in keeping infection levels low are now facing a much bigger surge with Delta in the winter than countries such as Portugal and Spain that did a worse job and are not having this winter surge yet. Well, I mentioned that you have to correct mortality for lack of registration. This is a problem everywhere. It was a problem at the beginning of the pandemic in high resource settings, even though they started to roll out testing earlier. But for the first 3 months, they missed many deaths in nursing homes. But it's remained a problem in countries with a lack of access to or sufficient access to testing and other health system barriers. Now, what we find out is that reported deaths are over 5 million. But the actual number of COVID deaths just through the end of September, so you need to add October to that now, are about 15 million. So we have about 3 times the number of deaths. Now that ratio is much higher than 3 in India. So here is the COVID-19 excess death rate. So this is the corrected deaths based on weekly or monthly death reporting, which includes many states in India from the civil registration system, corrected for under registration. You need to do that, but that's something that happens as part of the global burden of disease research each year. And there's a large team in India based out of the led by Lalit Dandona at the Indian Institute of Public Health, at the Public Health Foundation of India, my apologies. And he's also based at ICMR that do this work in India, including the under registration correction. But when we put all that together, you get the excess death rates in India that are on a par, despite, as we'll see in a moment, a younger age structure being quite protective, are on a par with the harder hit parts of the world, namely Latin America, Mexico, the southern states of the US, Spain, Portugal, and then the whole of Central and Eastern Europe. And then in addition to that, the cluster of countries in Southern Africa. The only places that have not had as high excess mortality are, of course, China, Australia, New Zealand, Taiwan, Singapore, very low levels, and then many countries in sub-Saharan Africa, or at least in Central, West, and East Africa. So large burden so far, quite a toll in India, as you well know. But the critical question is about children. And so there are data available on age-specific deaths that have been reported that allow us to look at the death rates by age. And this is our meta-analysis of that by, I'll go back up, by region. And this shows the characteristic J-shaped curve. Now, just to draw your attention, the y-axis here is a log scale. So above the first line here is a death rate of 1%, which in high-income countries, you get to a 1% death rate, which is, not the case fatality or infection fatality. This is just the death rate in the population. So extraordinarily high death rates over 75. And when we get down to children, the lowest level of risk is at age 7, goes back up under age 7, and starts this rise with age. So the death rate is 3 logs, almost 10,000 times lower at age 7, the lowest level, than it is at age 90. Now, you can see a little bit more precisely when we look at all the data. This comes from about 2,000 surveys of the seroprevalence surveys matched to age-specific death data. And this is from around the world. And what we see here is the infection fatality rate. So that's deaths divided by infections. And this relationship is incredibly steep. That is that as you go up a single year of age, the infection fatality rate goes up 10%. So that's a very, very steep curve. Much steeper, by the way, than the graph I just showed you about the age-specific death rate, because there's more transmission at younger age, and it tends to taper off after about age 50 or 60, partly because people are more cautious at those ages. But so this is taking deaths over infections, not deaths over population. And when you look at deaths over infections, you are definitely seeing this 10,000-fold difference from ages 85 plus to elementary school children. So a truly extraordinary age relationship where the beneficiaries of this are children. Now, what is fortunate for us all is that it didn't have to be this way. If you go back and look at the Spanish flu, for example, in 1918, the age pattern, the infection fatality rate, as best we know it for the Spanish flu, looked remarkably different. In fact, the highest infection fatality rates were at age 40, and then it dropped off from each side. So this is something specific to the biology of COVID-19. It's not a general finding for all respiratory infections. So children are at extremely low risk per infection for death. But there has been great concern about long COVID. And so we have conducted a systematic review of all the published cohort studies. The definitions we've used for long COVID are persisting symptoms after an acute episode of COVID-19 that is with new functional loss, not pre-existing symptoms. And the studies, as we've seen them, fall into three clusters: respiratory symptoms that are prolonged, post-acute fatigue syndromes, and then cognitive impairment, memory loss, loss of concentration. And this question, at least in some countries, around long COVID in children has been one of the primary concerns for keeping children out of school. So in the US, for example, a number of parents have kept their children home and homeschooled because they're concerned not about death, because they know the data is very low for the risk of death, but about this long COVID possibility with reports of myocarditis and other symptoms included. So we found through the systematic review 40 studies, 39 studies, 40 articles, plus we were able to access data from a nearly complete patient level data for the US. So hundreds of millions of person years in this data set, and then a not relevant to children, but a very detailed cohort from the Veteran Affairs Administration in the United States, and then 10 ongoing cohort studies where the authors of these cohorts volunteered to share data for the long COVID analysis. And here's the data by age, under 20, over 20. I'll give you more detailed ages in a moment. And this is distinguishing long COVID probabilities after a community case versus after a hospitalized case. The risk of long COVID is much higher for a hospitalized case than a community case. Now, it's easier to make sense of it on these results by numbers. So of those who have been infected, so that includes the asymptomatic, about 8% of children have long COVID symptoms, the average duration of which is 3 months. The percentage getting long COVID symptoms goes up, and it is highest in women at 21%, and is only 12% in men. Among those who have symptomatic COVID and who survive, the number for children goes up to 13.3%. Remembering that as far as we can tell, the fraction asymptomatic may be somewhat higher in children, but not dramatically higher. So long COVID is a real phenomenon, but the duration on average of these symptoms is not enormous. And of course, the cohorts haven't run long enough to know if there's a very long tail, but the median duration is about 3 months. Okay. Now, we've been talking about the impacts of COVID on the direct effects of the virus, both in terms of mortality, 15 million deaths globally, very few in children, is this very strong relationship with age. So it's really, as you get older, that's where the risks are very important, and then long COVID. But we've seen the effects of the pandemic on mental health. And this is not the effects of the COVID infection, but it turns out to be the isolation associated with the COVID pandemic, and particularly believed to be an issue for children who are getting, not what's quantified here, which I'll talk through in a moment, but also, lost opportunities for socialization and being with other children. But Damien Santamaro, Alize Ferrari, and colleagues at the University of Queensland conducted a systematic review of all the mental health studies that have been put out during the pandemic, and that they found, and then they put that data together and answered the question, what was the likely global implication? There's not enough data to distinguish by regional patterns. But what they found is on the top row here for depression, and the bottom row for anxiety, the left column is for women, the right column is for men, and it's by age on the x-axis. The red line is the increase or the prevalence of major depression or anxiety, and the blue is the pre-existing level. So quite substantial increase for women particularly, but also in men in both disorders due to the lockdowns during the pandemic. Now, another way to see these results, by the way, these results are published in The Lancet about a month ago, if you're interested in more detail. This is a population pyramid showing the baseline levels of major depression by age and sex in green and blue respectively, and then the effect or the increase in anxiety shown in red, and the increase in depression is shown in purple at the global level. And there's no reason to think these results do not apply in India, as far as we can tell from the results that are available at hand. So that gives us this clear perspective that there has been consequences of lockdowns above and beyond the virus. Now, by the way, that 15 million deaths, we don't know how many of those 15 million excess deaths are due to the virus itself, and how many of those are due to deferred care and other things that have gone along with the pandemic. That's extremely hard to separate those two out. The data to do that are not yet really available. Our best estimate of that is about 11 of the 15 million are due to the virus directly, 4 million due to behavioral change related to not accessing care, lack of campaigns in some countries, reduced immunization, a number of other impacts. Okay, now, I'm going to give you the explicit modeling of what, using our model at IHME, of what is the effect of opening schools on deaths in India by state. So how do we do this? Well, at IHME, we have a model. It's not just one model. We started modeling in March of 2020, at the beginning of March, as everyone was scrambling to understand the pandemic. And this model has had to evolve to take into account insights that have emerged as the science around COVID has advanced. So by May, we had a transmission dynamics model where we recognized that a coronavirus was seasonal in places that are at higher latitudes, that mask use was an important inhibitor of transmission, that testing per capita was important in terms of controlling transmission, and then probably most importantly of all, the social distancing mandates like school closures, gathering restrictions, and stay-at-home orders, business curfews, essential business closures. All of these had an effect on transmission, and so they've been brought into our modeling framework. We had to extend the model last year about this time to include vaccination. We then had to extend again to handle the emergence of the Alpha variant. And then we had to deal with the escape variants, Beta and Gamma initially, from South Africa and in Brazil. And then, of course, as Delta started to emerge in India and the full impact of Delta was starting to become clear, we added the Delta variant. And now we are right in the middle of a transition to a model that more explicitly takes into account waning immunity, both of natural infection and vaccine-derived immunity. So we have investigated, on the request of some of the people on this webinar, the impact of primary school openings in India within the framework of our model, looking at the statistical relationship between transmission and the different types of closures, in this case, school closures, and particularly primary school closure. And what we know is that primary school closure does decrease transmission intensity by some amount, very small, 1.3%. And we were able then to work in the past. So we look in the past and we see that primary school closures reduce transmission by about 1.3%, could be higher, could be lower, maybe no effect, maybe as high as 6%, given the uncertainties. And then we can look at what the marginal effect of opening elementary schools is on deaths in India. Now, if we had gone back and opened schools in India on September 1st, which did not occur, but some now are, there would have been 5,600 more deaths in all of India through till the spring next year, or through to the end of the school year, throughout the whole country. But of those 5,600 deaths, only 42 were predicted to be in children. And so that is a very small number of children dying from school openings that has to be balanced against all the other harms that come from schools being closed. Here's a more detailed way to look at it. This is the number, these little plots are for each state in India, the forecast with the school openings. And you can see that the solid line is what happens without the school lines. I mean, is the incremental increase with uncertainty on it as well. So, you know, it varies by state, but overall, the deaths in children are extremely small, given that small increment on transmission from school openings that we have seen statistically looking back in the past. And that's a zooming in on the excess deaths in under 18, extremely small numbers, as we have seen state by state. Okay, well, what should we be worried about that assessment? And I think the biggest problem for us right now, for us all, is to fully understand the rate at which vaccine-derived immunity wanes for infection on the one hand and for hospitalization and death on the other hand, and how fast does natural immunity wane. And I'll show you some evidence on that in a moment. This is the central policy question in high resource Northern Hemisphere countries as they are entering winter at a time when many people got vaccinated more than 6 months ago. But the debate rages on the protection from natural immunity. Here's a meta-analysis of data from Qatar, Israel, UK, and US. These are studies around, it says Pfizer, but it's actually Pfizer and Moderna. There are 4 lines shown here. The top 2 lines are the protection. Out in the solid line is where the data ends. Dashed line is a forecast. So pay attention to the solid line. That by 28 weeks, Moderna is still highly, highly effective with 90% protection and against severe disease and death. And by 28 weeks, Pfizer is around about 80% or 82% protection against severe disease and death, lower than what they start with. But for infection at 28 weeks, Moderna is down to 56% and Pfizer is effectively 0. Now, what this means is that we expect, as the dashed lines show, that vaccine-derived protection will continue to decline, and that protection against infection from Moderna will continue to decline, so that we'll have lots of people available to transmit once again, although many of them will still have protection against severe disease and death because of T cells and B cell mediated immunity, most likely. And so this is, a warning sign for our modeling, which does not explicitly take this into account. Now, the new model that's coming out probably in about 2 weeks from IHME we look for every single vaccine that we know of, and we look for its likely effect against infection and against severe disease at the beginning, at peak protection, after following whatever the vaccine schedule is, by variant. And then you can have these graphs on the waning efficacy by brand, where you start from the initial protection against infection and against severe disease. The colors there reflect ancestral in orange, and then the gamma variant, the Delta variant in the alternative color, or the escape variants in the purple color. They're all effectively over on top of each other. And then we see that protection waning. So in this model, and given what I showed you before, we are concerned that waning for vaccination will be quite substantial. And this makes the case that at some point when countries have access to sufficient supply, they are going to need to use boosters to sustain protection. The issue, as I've mentioned, is we don't really know what is happening to the waning immunity from natural infection. Why is this important to a discussion about children in India? Well, bottom line is, if there isn't a lot of waning of natural immunity, there is very, very small risk to children in India of schools being open. If there is waning from natural infection on some time scale, then we would expect transmission eventually to go back up in India. But even then, given the infection fatality rate we've seen, the risk to children is really very low. So while waning of natural immunity will dictate what happens to COVID in the next 6 to 9 months in India, there is not really, at least in our understanding, going to be substantial risk to children. So I'll stop there. That is a run through of sort of the global evidence as from our perspective around risks to children. The main conclusion from that is risk to children globally, and at least in the modeling for India, is extremely low from opening schools. Thank you.
All right. Well, thank you very much, Dr. Murray. I think that's been a fantastic presentation, eye-opening. I have lots of questions of my own, but I'm not going to be hogging up that space just yet. I want to once again bring in, our panelists and just do a brief introduction. I believe Dr. Madhuri Kanitkar, the Vice Chancellor, Maharashtra University of Health Sciences, is with us from Nasik, as is Dr. Swati Ghate, the Indian Academy of Pediatrics. She's also with us. Thank you both very much. Once again, quickly, if I could just open this up for initial comments. Dr. Kanitkar, to you first, your sort of initial comments on policy implications of this global data for India.
Thank you so much, Rishika. Firstly, Chris, thank you for that presentation, which was very lucid and informative. And I think it's really important to delve on these issues, because the cost of keeping children out of school, like we correctly mentioned and Rishika started the session with, is way beyond mortality and morbidity. And the question does arise in most of us pediatricians' minds that did we deny children something which was due to them to protect ourselves? Because at the end of the day, keeping them out of school for such long periods with such low risks that you have shown does show, and the harm that it is that, they've been denied immunization, nutrition, growth and development. The whole, and if the nutrition, we all know in the first 1,000 days as a pediatrician, I would say, and Swati would agree with me, it's the brain development which really is important. So is this generation really affected by keeping them away from that very, very important issue? That's my first thing, when I think this is really important that we discussed it. And having said that, and having looked at your data, could we have prioritized differently? Where the entire world is a question where we said, okay, frontline workers, healthcare workers, and things like that. If it was a child-friendly initiative and we were worried about people who have children, who have elderly people at risk with comorbidities, I mean, could we have at some point thought of them as to get them back at school earlier? The second thing that I think that we need to delve upon is a response to the vaccination. That when we are thinking of some of the countries have started vaccinating children, and what is their response? Because if they're at such a low risk, should it be like a public policy where we vaccinate all children, or should we just leave it to, yes, since we've seen that like the very young and the ones probably the adolescents, but at the real level which we are looking at, where children in primary school, do they really need those vaccines, is a question that comes to my mind. And I think I'll stop here before I come in again later, if Rishika permits, on the modeling that you did describe, because I've had some experience of being part of the Sutra team, which has done its own modeling, which has looked at various other aspects. So I think I'll leave the discussion here at the moment.
Right. Sure, Doctor, we'll bring you back into the conversation in just a bit, but I also want to bring in Dr. Ghate for comments here, because I think, one of the very important points that Dr. Kanatkar actually mentions here is if global data, as Dr. Murray has pointed out, says that children are at such a relatively lower risk, have we then kept them out of school for far too long in order to protect the elderly population? Dr. Ghate.
Thank you, Rishika, and thank you, Dr. Murray, for the wonderful and informative presentation. Yes, I agree perfectly with what Madhuri Madam has said. We have ourselves conducted few surveys from the Indian Academy of Pediatrics, and we have been showing scientifically that yes, children are suffering a lot on the psychosocial aspect. And the latest data has come up that 14% suicidality has increased among adolescents in the last year. That is really very alarming. We are afraid whether we are losing more children out of suicide rather than out of COVID infection. And when it comes to death due to COVID among children, they are particularly a group of children who are highly susceptible, maybe the chronically infected children, those who are on steroids, or those who are suffering from lung disorders, those who are leukemic or any other malignancies. So there are certain children who can be kept at home till we get a vaccine for them or whatever other protective measures. But in general, I have a feeling that yes, we can open the schools with all this data that is very supportive, that children are not at that great risk. We have in fact opened at various places and states in India, and apart from 1 or 2 hotspots, there had not been very many infections in the school. That is again very reassuring to us. So that is for now. And I would also like to share that we from Indian Academy of Pediatrics have come up with very robust and objective guidelines for school reopening, where we have put in some epidemiological parameters which could be taken help of, and the decision regarding school opening could be taken at the local level. If you permit me, Rishika, I will come back to it later. Thank you so much.
Well, absolutely. I think, Dr. Murray, the question here then becomes more about, has there been perhaps an inordinate delay? Could we have arrived at a lot of what you've said today sooner in order to prevent the kind of, loss in schooling months that India has seen? But then, the flip side, and if you'd just like to shed a little bit of light on that, is how soon could we have gathered this data, given the fact that COVID was a live and learn for everyone, including experts like yourself?
Yeah, I think that is a question that gets much debated. I remember, from a personal point of view, I have a 10-year-old, and I certainly was not comfortable sending my 10-year-old to school last year. We just didn't know enough, and what we saw, in Scotland, when Scotland opened schools in August, as Delta was sweeping through the country, you had, their Delta wave, they went up. Was obviously fortuitously, because they had quite considerable vaccination, nothing like what happened in India in terms of death. But it went up, came down abruptly, as it did in India, and then went back up again. And the reason it went back up again, so you had 2 Delta waves in quick succession, was, or at least as far as everyone can make out, is that they opened primary schools, but they did not have a requirement for children to be masked, and there was no social distancing in the school. And they had really explosive transmission in children, and then ripple back into their families. And I think many of us thought, oh goodness, this means that with so much more transmissible Delta, that every insight that we built up over the year for the ancestral and then alpha and beta and gamma variants was not going to apply to Delta. But we have not seen, I think most other jurisdictions with open schools have tried to, have reasonable mitigation in schools. So mask wearing, some effort at distancing, open windows, those sort of things. And we have not seen anywhere else like Scotland. We have not seen any other place with these explosive, or at least that we know of, transmission in schools. There are specific outbreaks in various places, but so it has not come to pass. And I think it's because, the mitigation measures help tremendously, as well as, well, actually, that's probably the main thing is the degree of mitigation in schools. So you can have a lot of transmission. So I don't know when we could have had a different choice. I think it was starting to be pre-Delta in the spring. I think most people thought we should get kids back to school because the infection fatality rate data was very clear. The long COVID data was starting to become clear that yes, there's long COVID, but it doesn't last that long for kids. So it's hard to say. I think probably the key question is sort of when you went through your Delta wave. In India, because you went through the tragedy of the first Delta wave, that gave you a huge degree of protection in the sense of for future until the next variant comes along, or if there is a next major variant.
Dr. Kanatkar, if you just want to come in here, because I think it's very complex for India in a lot of ways, isn't it? Given the fact that you have a vast majority of the population that still lives as joint families, which means that younger children have direct contact with family members who could be grandparents, who could be 60 plus. Does that alter the dynamics? Does that change the way we've done things? And the other question that I wanted to ask you was that, there is a lot of focus on primary schools and closing primary schools, because that's probably where it's hurt our education system the hardest. Do you think that, this could have been mitigated? I know there are 2 questions that I've thrown at you.
No, but I understand both. As far as, yes, the joint family and thing, I think at the pre-Delta wave, like Chris mentioned, the Delta wave swept through and really increased our seropositivity rate. Before that, I think it was very significant, and we could not have afforded to really get them back and get them to infect their grandparents. Second thing which has changed since then, and now we feel more confident, is that the vaccination has picked up. I mean, at that point of time, we did not have such high seropositivity and didn't have this kind of vaccination which was available. For a country this huge, I think we've done exceedingly well as far as the vaccination. And even if it is a single dose, we are seeing how it's protecting against mortality, morbidity, and hospitalization. That's where the health system really gets stretched out. So keeping that in view, I think sort of very early before the Delta wave, probably even hindsight says no. But after that swept in and we started getting in the seropositivity and we were seeing the kind of effect that the vaccine did have, we could probably go a little more aggressive and get them back at school.
Dr. Ghate, I know this is, well beyond the scope of any doctor or medical health expert to answer, but I think that one thing that really needs to be highlighted here is that when you talk about the Indian education system, there has been a huge withdrawal of students from primary education, also because of economic impact of lockdown, where there have been families that have just not been able to afford to put their children back to school or continue their education, and forget online education. I'm not even getting into the nitty-gritties of proliferation of phones or laptops or even television access in remote areas. But, coming back to the point of vaccination, I think one can't stress on this enough that we don't have a vaccine yet for children in India. Do you foresee this to be a big problem or a huge impediment when it comes to parents deciding on whether to send their children back to school or not?
Definitely. Parents are really worried to send their children into the schools before they are vaccinated. But it is our duty, it is our it is the lack of awareness probably that is hindering them from sending the children to the schools. And so we need to be more particular in sending messages across in the community that children, they don't need to be vaccinated. It is not an important step before they are sent to the schools. So as I was telling you, in our guidelines, we have drawn attention to all these things, that it is not necessary for the children to get vaccinated. And we have actually given three different types of sections in the guidelines. One is the general recommendation, one is the criteria for school reopening, and the third one is the criteria of attending the school. So it cannot be a general decision. Firstly, what we recommend is the decision of school reopening has to be decentralized. It has to be taken at the local level. What happened, just like Madam was also telling, after the first wave, the decisions were taken at the state level. Even now, the decision is taken at the state level. But then when it came to closing, like in Maharashtra, I remember Amravati was the first district where the schools were closed down. So opening and closing of schools should be at the district level, or even maybe at the city level, maybe at the taluk level, maybe at even at the school level, because things are very, very different for every area. That particular school, its infrastructure, what it can afford, whether it can accommodate the children, whether it can afford the school reopening, whether it is nicely prepared for that. So all these things should be, I think, decentralized, and a mass decision about opening and closing is something which is which puts a lot of pressure onto the system, onto the parents, and I think that there the things get troubled. So that is what we were telling, that about this decentralization of the decision. Promoting COVID appropriate behavior is very, very important, which we are like, I think we are going very far back on that, and social distancing and mask and all that, as you must be also aware that in India it is not being taken very particularly by people, and these isolation testing and all these measures and health system should be upgraded to take care of any unfortunate eventuality if it could happen. So that way also we are preparing, we are doing micro planning for all the districts, and we are gearing up, and our association is also doing a lot by bringing everyone on one platform.
Right.
Then that is what was the general, but three epidemiological parameters we have given. They are very objective parameters. Firstly, the case positivity rate should be less than 5%. Or if the case positivity rate is more than 5%, then the number of fresh cases should be decreasing over a period of 2 weeks. This criteria we have given. Then number of new cases should be less than 20 per lakh population per day for preceding 2 weeks. And 60% of the vaccine eligible population should have covered with at least one dose. So these are very objective criteria, and if these criteria are applied and the decision taken at the local level, I think we will not land much into problem.
Dr. Mari, what do you make of that criteria?
Yeah, I think having explicit criteria is very good, because it makes people have more confidence that there's a basis for choice. We can the challenge with sort of from a global point of view of any criteria depends very much on the infection detection rate, right? So the one thing we do know is, for reasons that are somewhat hard to fully understand, the infection detection rate remains low in India, even this far into the pandemic. It's on average about 5%. And to put that in context, the infection detection rate in Spain is 50%. So, you are still picking up a much smaller number. But as a sort of indicator of trend, that's fine, right? It's telling you what the direction of travel is. The other thing to note is that the case rates are probably your best measure of what's going on. If they're going down, that's a very good sign. Transmissions is declining. The thing, when we've studied everywhere, the case positivity rate, that turns out to not be predictive of anything. It's interesting because it's a mixed function. It's a function of what other viruses are around or things causing infection. It's a function of testing capability, and it's a function of so in fact in the Europe and the US, it has turned out to not be predictive at all. I haven't seen studies for India about above and beyond the case rate, is it predictive of what's going to come? But I think the main idea, which is to have explicit criteria that tell you that transmission is sort of trending down, is the right thing.
Dr. Ghate, sorry, if I can just come back to you at the moment, because I think it's very interesting, to look at the rural-urban divide when it comes to this criteria as well. Can same rules apply? I know you said that the decision-making has to be localized and it has to be based on a criteria. It can't be a one-size-fits-all approach when it comes to reopening schools or the manner in which they're reopened. But do you fathom there to be a lot of difference in the way your criteria, say, applied to rural schools versus urban schools?
Not really. In fact, I think in rural areas, it is much easier to keep a track of the local COVID like reporting and local COVID cases and all those data. That is, I think, much easier in smaller places.
Right. I do believe that we have a lot of questions that are coming in as well. So I'm not going to be, charged of asking all the questions myself. So let's try and include some of those questions as well. One of the questions, of course, is allowing the Pfizer shot for children. Does that conversation in a certain sense now change with the data that Dr. Murray has presented? Dr. Madhuri, do you want to take that on? I see you're smiling because this is a conversation I think we all had to no end as to why India doesn't have a vaccine for children.
No,
but lend a different perspective now.
No, I wouldn't really put all too many eggs into that basket for two reasons. One is Chris has shown us data which shows that vaccination of kids is not all that a big deal. And secondly, we are already having 2 of our own vaccines which have been sort of tested. And in fact, because of this data which is coming in, where first we felt we have to vaccinate all the children, from that we're getting into a little different thought process that do we really need to vaccinate? See, the tone is already changed. So in that, why are we pushing into something which, when we're going to have our own, and there are 2 candidate vaccines which have been tested and the results are there with the DGCA. And I think we would get a policy from that. So I think I would personally say we just wait and watch. And the second thing is we really don't have data to really support the thing of what's going to be the immune response in children, and whether it's of a natural infection. And because we are really going with more of adult data which shows waning antibody levels, we haven't huge amounts of robust data on cell-mediated and memory responses which are there. And the innate immunity and ethnic variation that we are seeing Could that have been, even to begin with, was that what really helped India, and whether it's going to keep helping them now? So all these other factors do come in. And therefore, at this juncture, with the available data presented, I think it's very difficult to be very dogmatic on either of these issues.
Right. Dr. Murray, you wanted to come in, and if I can just throw in another question, which is quite interesting, is, the risk when it comes to children, you've stated that very categorically in your presentation, is very low, and that we're not just talking about transmission, but we're talking about deaths. But morbidity among children, if you could just, focus on that. And I know you wanted to make another point as well.
So just on the vaccines, I completely agree on the sort of science front. I think we will, and we are seeing real reluctance for some parents of sending their children back to school, and in all countries, not just India. And it may turn out that the only way to get those children back to school is to vaccinate children. So it may turn out that we have to pay attention to what motivates parents. So there is obviously the scientific question about immunity and what are the sort of things, but it may also just be the case that if we really want children back in school, we have to accommodate those parents who are, because I have people that work for me who won't send their children back to school here until their children are vaccinated. So, and I suspect that's true in many places. On the morbidity front, I think, the specific morbidity from COVID is, there's a fraction, the infection hospitalization rate has run throughout the pandemic at 2%. There's a little variation, 1 to 3%, but basically 2 out of 100 go to hospital. That number is very age dependent as well. So very few children end up in hospital. Some do, but with comorbidities, but very few. So that the IHR, like the IFR, the infection fatality rate, is very age dependent. Interestingly, not as, so the IHR goes up about 5 percentage points per single year of age, and the IFR goes up 10%. So that gives you some idea that there's somewhat more hospitalization at younger age than death, but still very low. And so then the real issue is usually in these considerations is the long COVID part, which I showed you before, which is real. It is going to be, 10% or so of children will get long COVID, but it is of a finite, the median is a finite duration of about 3 months.
Right. And I think, the data that you highlighted earlier was that had India reopened schools on the 1st of September, we would have probably had 5,000 more deaths, but only 42 among them would have been for children in the age category of children. So I think that data in a certain sense really explains it. But the other really interesting aspect here, Dr. Ghate, is inspiring confidence. And I think Dr. Murray really hit the nail on the head there, because for the section of our population that actually has a choice or has the privilege of having a choice, what according to you would inspire confidence? Because we do know that as a country, we've struggled to put our kids into schools, and education has generally come very low on the criteria because, of course, income generation comes higher on the criteria. So, what would inspire that confidence? Do you think there needs to be more awareness, more conversation around it?
Yes, definitely. More awareness, more conversation, and laying down definitive criteria of who all can attend the school. Like if you say that all the adults in the household are vaccinated, then only the child can go to the school. So then some objectivity comes. Parents can take decisions very clearly. They are less confused. So if you say that if the child is a chronically ill child, he has to first take the opinion of his pediatrician. Then only he can go. So obviously the other children, parents get a feeling that, yes, I can send my child to school. So such objective criteria have to be laid down, and they need to be disseminated so that parents get confidence. The school authorities, they should declare that all their staff is vaccinated. All those who are attending the schools, the drivers, those who are picking and dropping the children, and everyone around who is in contact with the school premises is vaccinated fully. So such things will generate confidence into the parents, and school and parent, they need to come together to take such a big decision. School has to involve the parent body also. So what they want from the school, what sort of a collaboration they can do. So all these things have to be done,
Right.
and only the school reopening and sending them will be an easier task for the parents, I think.
There's a question that's come in about why children are at a lower risk. Can you, Dr. Murray, would you like to take that on?
Yeah, I mean, there's a bunch of theories that are out there. Some have to do with the expression of, receptor binding sites. Some have to do with the waning of immune function that we know about with age. Think about tuberculosis, where we see not as extreme, but a similar phenomenon where there's age-related energy or waning of immune function with age generally. So it's not unusual to see an age pattern in the case fatality rate for an infectious disease. It's just in the case for COVID, it's more extreme than what we normally see. And in some cases, flu has a very different age pattern, but in other cases, it looks the same. So lots of mechanisms, but mostly related to the ages at which different aspects of the binding site gets expressed, and also the general waning of immune function as you age.
Right. I know that when you were explaining the J-shaped curve, you talked about how children under the age of 7 are at the lowest risk. There's also a question coming in on what happens in teenagers. For instance, the age group broadly, say between 13 and 19, 13 and 18, are those children at a relatively higher risk, and why so?
Yeah, that 10% per single year of age increase starts at age 7. So you're at lowest risk at 7. So a 17-year-old has, not exactly, but about 100% higher risk than a 7-year-old. Still, it's a very small risk, right? So if you saw that graph on the log scale, but it is a higher risk. It's also higher for a newborn, which most people don't realize, right? Your best age is 7, as is true, by the way, for so many causes of death. The lowest death rates in life are usually around about age 7. In most populations in the world, and so shouldn't surprise us. But it does start to go up, and so it's been in some places this funny inversion where people have thought that adolescents were at less risk than elementary, but it's actually the reverse.
Right. Dr. Kanitkar, this is exactly what we've been talking about when it comes to mindset and inspiring confidence. And I know that, vaccination is only one part of it. What Dr. Murray has highlighted is, of course, that, even with very little really known about natural immunity waning, vaccine immunity, the data that he presented from Pfizer and Moderna has shown, that sort of downward trend. The question really is, and this is one of the questions, that's once again been asked in the question box as well, which is again the risk of transfer from children to adults. Now, this also is with the premise that because children are lesser affected or have a better ability to deal with COVID, a lot of times they're asymptomatic and therefore more dangerous.
That happens in any situation. It is, in fact, this was exactly what was different about this, the SARS-CoV-2 virus, that to begin with, it took a little time for us to figure out this asymptomatic and the impact of it. And that is how, like Chris mentioned, where the SAIR model or the asymptomatic cases started, and there were very few initial reports that they do have this thing. And to begin with, in all these models, we used that their ability to infect others was almost as equal. But even from that, we've now come to the recent data shows that the asymptomatic, the level of viral shedding and the duration of viral shedding is probably lower than the people who are symptomatic. So that's one thing. And the second thing is, yes, there was initial NIH studies which did show that the younger children were probably shedding more viral load than the older children. But now, this is all initial data which came in. But today, and at the initial, we didn't even think that mask was a great big idea, right? So, whereas now we have seen that the non-pharmacological interventions of distancing or use of masks, the evidence came in later. It was initially, in fact, India was one of the first nations to bring out a guideline for use of a cloth mask. So, and that has shown to actually been an effective non-pharmacological intervention, which has really helped. But in that, when we are doing this modeling, we need to take in that accounted for, so where you have your symptomatic versus asymptomatic cases and what is the transmission, and more important, how your lockdowns and those also have impacted. So whether it's in a small group, and that is where I'll bring in the Sutra model. For the first time, we looked at a fourth parameter, which was the reach parameter. I mean, this really was not only about the beta, which was the chance, or what was the R naught, which we used to, in a normal mathematical model. But we found that, and this is actually what happens, that in the beginning of a pandemic, the gated societies, we did find that during the first initial, there were a lot of people. We cannot assume that all were equally susceptible, because some were just excluded and cocooned off. And it was only over time which it reached into. So when we started seeing the second, it went more into societies. Our first lot, the people who were hit were the ones in what we call the Juggi Jhopdis, the slum areas, the absolutely congested areas. The second lot, it came in when this came into the homes, and people had been relatively protected during the first wave. So this has been a continuous thing, and that is where we modeled in it as a reach parameter. So if we've said that everyone has, and your adults are at the level of say 70%, as Chris showed, the children would have in that household, if the adults are 70%, children would have had an almost equal chance. That means the virus has ability to, or the reach has already reached them. And therefore in that, the Indian Academy of Pediatrics has done some good this thing, and some cities we have some data coming in. So I think we would need to really look at adult seropositivity versus pediatric and age-wise seropositivity to say that how much of them are anyway quite safe. And this could actually also add as a convincing factor to tell parents who are kind of little skeptical. So I think that could be added on to this.
Right. Dr. Murray, also questions about, whether data can actually be, in a certain sense, be extrapolated for us to call it global data. We know COVID has played out differently in different parts of the world for multiple reasons. So question on, whether or not there are limitations to this data on applicability to India.
There are biological aspects to COVID, and then there are very dominantly, as we just heard, the sort of social construction of how COVID transmits in a given place and who is at greatest risk. So the part that seems generalizable or held up very robustly, for example, in all the empirical work is, for example, the age pattern of the infection fatality rate. There are now a couple thousand places where we observe both the age pattern of infection and the age pattern of death. And every single one of them shows this very steep relationship with age. And it's really quite consistent. So, we should be very confident about the age pattern of the infection fatality rate. The level varies. And there are some parts that we don't understand. For example, the infection fatality rate, given that very strong age pattern, the dominant determinant at the population level is just the age structure of population. But there's plenty of other things that influence the infection fatality rate, the presence of diabetes, chronic obstructive pulmonary disease, smoking, high blood pressure. These are both found in patient level studies, but also population level studies. And then there is a component that we can't explain. For example, the IFR is lower than we would expect in many countries in sub-Saharan Africa. And so is this some other aspect of immunity that we don't understand? Is it prior exposure to other coronaviruses? There's all sorts of theories, no real hard science. So there is real variation in that, but I think we can tease apart which parts are, very generalizable because they're consistent evidence, and those where they're not. On the incredibly effective nature of the non-pharmaceutical interventions, the lockdowns, the business closures, mask use. Again, mask use is biological. It's a physical barrier. Quality of mask matters, particularly for you being protected. What we think we know from the mask data is all masks are about equally effective at stopping somebody creating, particles that somebody else can inhale, whereas protecting you on your side, an N95 is dramatically more effective than a cloth mask. Put those together, though, at the population level, cloth masks work rather well, but N95s, as we know from healthcare worker studies, are almost perfectly effective. So if we had everybody wearing an N95, we wouldn't have much COVID. So we do have within our means the possibility of really stopping transmission, and it's something for us to think about for the future, for future pandemics, given how effective the non-pharmaceutical interventions have turned out to be. But then there are things like school closures that do statistically seem to have different effects in different regions. No effect at all on transmission in some parts of like the US, and then in Europe, quite a substantial effect. And it has to do with what happens around school. What do the parents do when kids go to school and when they don't? What happens around children being sent to school, and are parents walking them back and forth to school or driving them to school in places where that's the culture? So there's this really complicated social pattern that relates particularly to schools, so that we should expect the combined effect of school closures to be somewhat different in different parts of the world.
I also want to ask, about why children then in some parts of the world have been given a vaccination and not. I think that's a question that's a question that a couple of people have actually asked. If this data is, to be believed in that sense, then you don't need to rush vaccination for children anywhere in the world, because that's again something that doesn't inspire confidence if that's what we're talking about here. Would any of you like to take that on?
I think on least I can jump in on the US discussion. I think some parents are really concerned about long COVID, and so they really want vaccination to deal with the COVID risks. And then there are fewer than in India, but there's still many families where children are exposed to their grandparents, either at home or nearby. And so people are concerned about children transmitting back into the family. So those are the two that tend to drive most of the interest in protecting children. There's also a lot of media about relatively rare outcomes, Kawasaki-like syndrome, for example, that has made parents very anxious. So there's also the classic issue about risk perception as well.
All right. I think closing comments, Dr. Kanitkar, you first.
No, I think my closing comments would be that COVID has taught us a lot. It's really sort of made things, and science has been able to analyze some things like the data that is presented, that it's added to a lot of knowledge pool by hindsight. And should we happen to have an episode like that, I think the entire world is better prepared. It also showed us that it is the public health which really matters. It's not at the individual level, but policy decisions which affect the maximum are going to be more useful than thinking of individual, should my child get a vaccine or should my person get a thing. I think these good decisions which were taken where the world came together, where vaccines were produced in a record time. I think most of us had, most of the population would have hardly heard of a coronavirus or today, and look at it. I mean, look what a year and a half has done to the world. So I think there's a lot to learn, and let's look at the positive aspects of it, and that we are very well prepared for any such calamities in the future. And we should keep learning from each other with such sessions.
Right. Dr. Mari, very interesting question. And I think I missed that while I was scrolling. One about, whether there's any kind of a networking parametrization that's been done between school-going children and adults going to work. Can there be that kind of a comparison even made? Is there a model to do that? That's a question that someone's asked.
There is quite a lot of data. I mean, what's special about COVID that wasn't the case in the past is this, that the tech companies, particularly Facebook, has been running a survey every day since the beginning of the pandemic. And they've surveyed, I think, 80 or 90 million people worldwide. Now, obviously, there's all the questions about who gets access to Facebook, et cetera. But it is 90 million responses of a very detailed nature that gives you daily tracking of mask use, of are you going to work, are your kids going to school? So there's a lot of data at the household level that can be analyzed for the future to understand those relationships. And I think, unfortunately for us all, COVID is not over. I think we will see some more twists and turns from this virus. We will see more COVID than anyone expects to see because of waning immunity, and we may have new variants. So we will still be talking about COVID next year, even if it's hopefully much less destructive. But I think, as we just heard, learning from all these experiences so that we're better prepared for the future is super important for us all.
Right. Dr. Ghate, closing comments, and I just have two quick questions, which is also something that people have asked on as we're talking about this whole inspiring confidence exercise. I know you have detailed criteria laid out. You've established that this needs to be hyper-local decisions. The use of an N95 mask is something that you all talked about. Is that safe for children? There's been a lot of debate and discussion around mask usage in children. Can children, as they go back to school, unvaccinated, should they all be wearing N95 masks? One hasn't really heard of that.
Not N95, but children are supposed to wear a 3-layered simple mask, and it should be snugly fitting. Important is how nicely it is fitting and covering the nose and the mouth area right up to the chin. So mask manners, they have also to be taught to children. While we prepare them to go back to school, we have to train them in a very different way. How the school will look differently, how the children will behave differently, how the teacher will be away from you and not cuddle you. All these things need to be told to children. And reopening is not just a simple thing. It involves a lot of preparation on the school side, also on the family side, for the student side as well. So below 5 years, we are not expecting children to wear masks. And
yes.
Above 5 years, yes, but they should be, because they understand that if they are getting difficulty in breathing, they can go and tell to their teacher or to their parents. So that can be, and I am very happy to tell you that children are accepting masks very well, and even they are all asking their parents to put on the mask.
Okay. Okay. We have
So
we have a very serious this mask manners that you've talked about. I think that this is something that applies across the board. I don't think these mask manners need to be taught to children only. I think mask manners need to be taught to adults as well, especially here in India, especially if you move out of urban pockets. If you move out of Delhi, for instance, 50 kilometers out of Delhi, you barely see anyone in a mask, let alone wearing it properly. So I think those are conversations for a later date, but I have to give you, Dr. Murray, the last word.
So thank you very much, and thanks for what was a very interesting discussion. I think there's been far too little of the discussion of balancing the health effects versus the other effects like lack of education. What are the long-term impacts on human capital? So I think those issues really do need to come to the fore. I know that the World Bank is starting to try to bring attention to that more. So the message is starting to get out. I think it's a very important one. So I was glad to see this discussion.
Well, absolutely. I think I just want to say, at the end that in India here, it's been a conversation between life and livelihood. That's the balance. I think we've graduated a little more beyond life and livelihood now to really looking at the impact that COVID has had on India as a country, on us as a society. And I think children really come at the very forefront of that conversation, because while we've adapted to different ways of working, traveling, adjusting, I think the setback that children have faced, and I'm really glad that you mentioned the mental health impact. You've spoken of long COVID in children who suffer, and just understanding that the impact that COVID actually has on children isn't as severe, thankfully, as it is on the older population. I think a lot needs to be done to make up for the loss, especially that children have had in the last 2 years by not being able to go to school, not being able to interact with their peer groups. So I think it's going to take a couple of years to undo and sort of just relook at just how these 2 years have set us back. Because, people in the education sector who we speak to constantly say that, it's not 2 years, this has set us back much, much more than 2 years. Just going into people's homes and bringing children back to school is going to be so very difficult to do. So one sincerely hopes that this conversation's been an eye-opener, and we hope that there's a vaccine for children soon as well. And we really hope that this data is widely publicized and talked about, because it is indeed very heartening. Thank you all very much once again.
I just want to add a few closing remarks from the organizers' side. I want to thank, of course, Chris Murray for putting this presentation and bearing with us for the last 2 months, because it's taken us a while, so it just didn't happen yesterday. But then also the panelists, Dr. Kanetkar, Dr. Gate. In addition, I want to thank all the sponsors, which includes Indian Institute of Public Health in Gandhinagar, COMAD, Indian Academy of Pediatrics, and other groups. So I want to thank everyone who supported this process. And also I look at it that this is not just the end of this discussion. We hope to continue this dialogue. And we hope to work with IHME and Chris on this, because I think often there's a lot of data. The challenge is always in terms of how we influence policy as well as programs. So I want to thank all of you. And finally, I want to thank Imran, who also was behind the scene working on the logistics, and then also Anna from IHME, who also played an important role, as well as other staff from IHME. So thank you very much. Till we meet again in the next forum, I do welcome. And also, Rishika, I forgot to acknowledge you. It was really, you did an amazing job in sort of responding and raising questions, as well as addressing the questions that various participants raised. So thank you all, and thank you all the participants. We'll make the recording available as well as the presentation in the next few hours, and we'll also send it out in a social blast to everyone else in our mailing list. And I hope you will also do so. So again, thank you very much for joining today's meeting.
Thank you so much.
you.
Thank
Thank
you.
you.
Bye.
Thank you so much.
Bye-bye.
Thank you. Thank you.
Bye.